Mayo Clinic presents the Always On EM podcast, hosted by Alex Finch and Venk Bellamkonda. Welcome to Always On EM. This is a podcast from Mayo Clinic. My name is Venk Bellamkonda.
I'm Alex Finch.
We're your two co-hosts, and today we are incredibly grateful to have our guest today, Dr. Dagny Anderson. She is a senior associate consultant in the Division of Pulmonary and Critical Care Medicine here at Mayo Clinic. She is a rising star in that division and is finding ways to reach learners on some challenging topics to teach, such as having created content on how to handle missing data in research. She also helps the MD PhD students with their re-entry into the clinical space and has also been involved in updating the medical intensive care unit curriculum for trainees, and she does so much more. She has been an up-and-coming invited speaker in many arenas, nationally, regionally, and locally. And so, Dagny, thank you so much for joining us today.
Thank you. I'm incredibly grateful for the invitation.
We're excited to talk about a difficult topic today, and I was sharing that this topic has really impacted my career in a variety of ways. And Dagny, if it's okay, I thought we'd start with a case of a little bit how bad this can get, and then we'll rewind and talk through the spectrum of disease. But let's say you are on service, and I know you work a variety of clinical roles. What areas do you work in?
I am working throughout the realm of interventional pulmonology in the bronchoscopy suite, on the inpatient pleural service that also handles calls about hemoptysis or other airway concerns on call duties. That's
really incredible. I think interventional pulm is just such an incredible service. When I was a resident, I got to rotate, and we place these emergent chest tubes and pigtails, but the elegant way in which your team is able to do these procedures is aspirational. And it's the reason why we call when sometimes our back is against the wall. And let's start with a case that I had a couple of years ago. I had a female patient in her 50s come in, and she was complaining of a cough and had actually been in the emergency department for a while, feeling a little bit unwell, and it wasn't super clear what was going on. She got back from CT. I scanned her chest, and it basically showed a known malignancy, but not a lot else. And all of a sudden, a nurse came out and said, the patient seems to be vomiting blood, was what it was initially described. And it was that moment, where on the back of your neck, the hair stand up, because there was concern, but it didn't seem terrible yet. And I turned to my senior resident, I said, I think we better get to that room right now. And we walk in, and initially I was thinking, is there some sort of massive GI bleed? But it didn't seem like the patient was vomiting, but it also wasn't super clear what was going on, to be honest. But there was it was coming in small spurts, and suddenly there was just blood everywhere. And the patient wasn't able to breathe, and it very quickly progressed to a cardiac arrest. And all these moments in my training that I'd been considering, things that I'd been told, maybe you'll never do this in your career, a crike, maybe you'll never do this in your career, this amount of bleeding coming out of the airway. It was suddenly coming in front of me and happening in that moment. And it was an incredibly humbling experience to be thinking through these procedures. And at the end of the day, I was left with this topic, massive hemoptysis, and feeling humbled by something that, in retrospect, I didn't know enough about in my training. And I realized there's this whole spectrum of disease, from somebody who shows up and says, I'm coughing up a little blood, to a patient who unexpectedly I walk in and is about to code. And that's really what I need to learn more about today. So overall, I have this critically ill patient, and in that first moment, what could I do to try and make things better?
Well, Alex, I think you've evoked a very similar set of emotions that quickly flood through when a patient suddenly deteriorates. And I've had a few cases that stand out in a very similar manner, and you pointed out this difficulty, which it doesn't seem like it would be challenging, but I've had the same trouble in distinguishing, is somebody having hemoptysis? Are they having a GI bleed? I've been in that exact same circumstance of trying to distinguish those two, what seem like very different pathways, in the role of the rapid response fellow, for example, in training. And that is in itself a humbling moment to think, goodness, I myself am having difficulty distinguishing this with pulmonary background. I think even if you are still unsure of which route the blood is coming from, just from the situation you described, that significant deterioration, certainly one of the first steps in stabilizing that patient will be pursuing airway protection, in addition to securing IV access if it hasn't already been secured. And all of these things are happening concurrently in an emergency department that thankfully has folks like yourselves that are very even-keeled and equipped to handle these emergencies. I think a very basic starting point would be what size endotracheal tube to reach for, and just have that kind of memorized in mind for when the situation happens again. And thinking that a size 8.5 endotracheal tube or greater is ultimately going to allow for the types of tools that are going to be needed in this scenario to be passed through the tube. And so that is always one of the first questions when interventional pulmonary, for example, is being contacted about a similar case once that airway is secured, is what size tube? Because we're thinking, are we going to be able to use a therapeutic bronchoscope? Are we going to be limited to a standard scope or even a disposable scope, for example? And your suction power is going to be so much weaker with anything other than a therapeutic bronchoscope. And additionally, some of the modalities that we're going to be talking about later, for example, placement of an endobronchial blocker, use of a cryoprobe if you need to fish out blood clot, is really only going to be feasible with a larger scope size. And so I think that initial reflex from the emergency department side of securing an appropriately sized tube would be helpful. Worst case, if you need to, you could certainly exchange it over a bougie later, but it just would be a lot more efficient to go for the right size tube from the get-go. Mm-hmm. And then you had mentioned in that specific case that the patient had already returned from their CAT scanner, which wouldn't have always been done. Like, let's say she had deteriorated right from the get-go, and you really have no sense of what side this could be coming from unless they happen to have recent imaging or a really compelling, already known reason as to why they might be having hemoptysis. In that situation, certainly would have somebody in the room pulling up that scan just to get a sense of, is there any unilateral process that's occurring that's going to immediately impact what positioning you would want that patient in as soon as that breathing tube is in place. Okay. It can be challenging when patients have bilateral parenchymal opacities or abnormalities, and you're really stuck. You don't know which side it could be coming from. And even if you argue, oh, there's a little bit more bronchiectatic change in the right lung relative to the left, I don't know in that moment if it necessarily means that the right lung is more prone to bleeding or not. It could still be from either side. But occasionally you will have somebody that has a clear-cut mass on one side and very normal-looking parenchyma on the other. And in that situation, I would have the patient rotated into the lateral decubitus position such that the bleeding side is down. And it's a true rotation, like you're sleeping on your side, on your shoulder, on your hip, rather than just a slight tilt. You really want to isolate the bleeding side down so that you can preserve aeration to your non-bleeding lung.
That's phenomenal. And you mentioned a couple of things that I think in my head, I'm approaching it differently. And so I've really learned something. So in the moment I was thinking, I want the best tube that I can get is the one that I can do immediately now. And so I was cheating down a little bit because my patient was now hypoxic. So I went for a 7.5 tube. And so I had no idea that I was already limiting a future intervention. And would love to get your idea on some difficult airway management topics from a pulm crit point of view. But so we were in a situation where the oropharynx was essentially full of blood. And so it was our VL kind of wasn't an option. We were DLing and not seeing any structure. So we were trying to do double suction. And it was kind of at the point that we were looking for bubbles of air. That's kind of what we were doing. And ultimately, it was a situation where we were faced with blindly passing a tube towards bubbles of air and then proceeding with a surgical airway.
Alex, at this point, is your patient in cardiac arrest? I'm wondering, are they needing medications for this intubation?
My patient required no medications at this point and was hypoxic, I would say. We're satting, 60%. We're feeling for a pulse. Our pressures are hypotensive at this point. And we have a pulse during the intubation, but from hypoxia, we're progressing down a bad pathway. And so at this point, we've proceeded to a surgical airway. And a little bit along the lines of what you were saying, this could be a GI issue. It could be hemoptysis. It's a little unclear, but our key diagnostic step and therapeutic step was to try and get a tube in, because at a certain point, if I get the tube in and there's still blood coming through it, I have my answer. And we're so fortunate at Mayo that there's so many experts available to us. I delegated involving some other teams. So I actually, as I was moving through this surgical airway, I was able to ask our staff to page the GI bleed team and our pulmonary team just to start trying to get things going, because I was at the point where I felt without immediate action, we were going to lose this patient. So I proceeded with a surgical airway, and at that moment, I'm getting blood back through my endotracheal tube. In that moment, what steps could I take then to try and optimize my outcome? At this point, you had already mentioned rolling a patient on a side if I have an idea, which is a phenomenal suggestion. Are there any other steps I could take at that point as an emergency doc to try and make things better?
Absolutely. I think recognizing that calling in other teams is a very wise step. One thing that you could have those consulting services providing an opinion about, let's say they're on call at home or they're going to be rushing over from another case, at least they can be pulling up that CAT scan that was just performed for this patient to help give a rapid interpretation, especially if the read isn't back yet, about which side would make the most sense to roll the patient towards. Other things that can be happening in this moment are doing your best to suction out the airway, get a sense of, is there any ongoing active bleeding? It can be very challenging when you have blood on both sides. It can feel, my goodness, like how am I going to distinguish where it's coming from? But kind of clearing it to the best you can, and then watching both sides going back and forth between them to get a sense of is one side kind of staying clear and the other side refilling will be helpful in kind of corroborating whether you pick the correct side that you think it's coming from. Other things would be to have kind of going on behind the scenes would be to be checking coagulopathy parameters and addressing all of those.
Phenomenal.
Assessing whether a patient has been on any anticoagulation or antiplatelet agents, or let's say they were initiated on a heparin drip for who knows what reason already, and not overlooking those steps, because there's a sense of adrenaline running through the room in these situations. And so, as silly as it seems, it is helpful to really be forthright in saying, what medications are running? Is there anything currently that could be exacerbating a bleeding situation?
I think that's a phenomenal suggestion. And I remember in the moment thinking, there's a lot of blood. And as a trauma team, we're looking for blood on the floor too. And so I was calling for transfusion. And like you're saying, there's adrenaline. Somebody was saying, well, do we just grab one unit? We have a little blood supply in the ED. And I just remember saying, all of the blood. I want all of the blood in this room right now. But it doesn't take that much blood to arrest from this pathology. Is that right?
Absolutely. It only takes about 150 cc's to fill your central bronchial tree. And in the literature, you'll see different definitions for massive hemoptysis. And it's amazing how challenging it is for patients and providers alike to really quantify that. You were saying, you're looking across the room, where has the blood splattered to? And trying to equate that to a cc amount is almost impossible, even for trained medical teams. Here you have a number of issues that have already kind of defined the situation as massive hemoptysis, and that you have a patient near cardiac arrest, you're resorting to blood products, you've had to intubate the patient. So all of those kind of, regardless of the actual amount of blood that's been expectorated, is clinically such that we would treat this as massive hemoptysis.
Let's say this patient was different, though. What are some of the criteria that you would recommend, even if there are varying numbers?
I think a generally agreed upon number would be 500 cc's over the span of 24 hours. Another would be sort of a sense of that this is a very brisk bleed. So let's say only 100 cc's within an hour's time.
As Dagny mentions, there are several different criterion that are proposed or used throughout the literature. In my search after our interview, I found references ranging from 100 cc's in 24 hours all the way through to 600 cc's of blood in 24 hours. There was less variability when looking at the hourly rate, which the 100 cc's in an hour does seem to come up quite frequently. Yet, given the overall variation in trying to quantify the amount of bleeding, it's generally not considered ideal to use that as the sole criterion for determining something as life-threatening hemoptysis. Instead, it's recommended that we incorporate the identification of impaired gas exchange or hemodynamic instability when making that determination.
Well, it certainly felt like I was at that spot. So at this point, I have the endotracheal tube. I have blood coming out of it. And so I had my finger in. I felt the cartilaginous cage. So I feel that my airway's in the right position. You started to say, well, I'm going to test both sides. From an emergency point of view, we're fortunate that we do have a bronch tower, but there's so much blood it's hard to see. In the situation where I'm dealing with kind of a blind situation, what techniques would I do to try and selectively intubate? Because I think that's what we're talking about. I'm going to try and main stem my tube to protect one side. How can I navigate that?
Absolutely. So that is a very effective strategy if you are confident as to where the bleeding is coming from, either based on your imaging or the look you've had in the airway so far, or a combination of those two. Certainly it's easier to selectively intubate the right mainstem bronchus just because of the angulation of the airway and the breathing tube naturally finding an easier pathway down that side. But you could...
I think you're saying push until it stops, just like... just.
If the concern, though, is that it's from the left side, it will technically be more challenging, but using your, whether it's a disposable bronchoscope or if a therapeutic bronchoscope has arrived from a consulting service, using that sort of whatever rigidity of that tube you have, the bronchoscope you have to glide your tube into the non-bleeding lung would be your next step.
I think I'd read also about one technique. Our comelastic bougies, we have Frovas here, and they're angled, and so trying to, if I can move it to the left in a blind situation or move it to the right, that might be better than just trying to force down my right main stem. I don't know if that's the right thing to do. Would that be, if you're back against the wall, is that a reasonable option?
I think it is any method that can be used to temporize a situation and to try to selectively intubate the non-bleeding side.
Alex, certainly in this case, you had a CT that might point you to one side or the other, but what I really struggle with, Dagny, is when there's absolutely no way to predict right or left side, how should I approach managing that patient once I've got plastic in the trachea?
I think at that point, once you have your breathing tube in place, reaching for the largest scope that will fit through that breathing tube in that moment, and using it both from a suctioning standpoint and even just as a mechanical tool to, for example, push any formed clot out of the way. Suction to the best of your ability. If you need to run some saline through your channel, especially if it's becoming obstructed, and using any sort of visual clues in that moment to get a sense of which side has brisker bleeding. Certainly recognize that there are going to be times from what this case kind of evoked that visualization can be extremely poor. And we are spoiled from the interventional pulmonary side of having access to much more powerful scopes and suction power. I think there would be some liberties just recognizing that while awaiting for that equipment to arrive, that if absolutely necessary, if there's still no sense of which side it's coming from and just more of a kind of trial and error standpoint of trying to selectively intubate one side and just get a sense of quickly, is there any sense that the clinical trajectory is getting better or worse, would be a worst case scenario, but a valid attempt of trying to control what's otherwise a rather uncontrolled situation at this point.
The other question that is coming to me is, we've talked about the mechanical techniques, and this patient's hypotensive during your airway interventions. I often would give some pressors to try and bolster that while I'm trying to secure this airway. At the same time, I'd worry that that's going to make the bleeding worse. What do you both think about this?
I would say in that moment, to stabilize the patient from a hemodynamic standpoint, that volume resuscitation plus pressor use is perfectly acceptable, just to not have sort of a new problem number one evolving during this hemoptysis episode. And any worsened bleeding related to vasopressor use, I think, can be combated by use of other techniques. For example, figuring out which side it's coming from, selectively intubating the opposite. There can be use of cold saline or other sort of tactics that can lead to some vasoconstriction to try to help control the hemoptysis as well.
Venk, I think that's a great question. I agree with resuscitate before you intubate. I think,
or maybe while you intubate.
Yeah, at the same time.
I don't think you can wait. But.
Yep. We're not bagging in this situation, that's for sure. So I think that is all well done. But the other aspect is what other medications can I be giving? I think about things like TXA outside of reversing an obvious coagulopathy from anticoagulation. How do you feel about TXA, or what can I do with that?
There is at least low-level evidence to support the use of TXA. In one small randomized control trial in a much less dire situation than what this patient was experiencing, was exploring the use of nebulized tranexamic acid for patients that were admitted to the hospital with non-massive hemoptysis, and randomizing either to receiving 3-time daily nebulized TXA versus placebo up to 5 days. And those patients that were in the TXA arm ultimately had a lower volume of hemoptysis. They had less need of procedural intervention, whether it be bronchoscopy, IR intervention for bronchial artery embolization. They had shorter length of stay and less recurrence. So I think it is a valid medication to use in a non-massive episode. And one way that we use it in the bronchoscopy suite rather regularly is topically. We instill it through our flexible bronchoscope. We often use 500 milligrams and about 5 milliliters of saline and inject, and then the key is not to immediately suction out that medication, just to give it some time to take effect. So you'd want to wait to suction for at least a minute, maybe a couple of minutes. And if there's, let's say in a case where you have more visualization and you can get a sense that it's coming from the right lung, maybe to a specific lobe, even if you don't have necessarily a segment identified, but if you can isolate to a lobe, you could drive your scope there, instill that TXA, hold the position of your scope to try to keep that medication, keep blood distal to where your scope is, wait that minute or 2 minutes, and then back away and get a sense of what effect you've had. And thankfully, it works rather quickly. We use this often after bleeding that we encounter related to the different forms of biopsies that we take in the bronchoscopy suite.
This is Venk jumping in. Dagny did a great job of talking through some of the evidence behind nebulized TXA for hemoptysis. You may be wondering, what about intravenous or systemic TXA? There was a pilot randomized controlled trial published in Chest 2023 with the lead author Bharath Gopinath, and this compared nebulized versus intravenous TXA for hemoptysis. There was no control where the patients did not receive TXA. This was an ED-based, open-label, randomized trial at a large academic ED. Couple things to note about this study. One arm had nebulized TXA 500 milligrams given on arrival and then 3 times daily afterwards, and the other had IV TXA given 500 milligrams at arrival and 3 times daily afterwards. Both sides of the study went until 72 hours had passed, or the patient was discharged or received some definitive care procedure. Both sides enrolled 55 patients, and the majority of the patients had minor or non-life-threatening hemoptysis. The median volume of blood calculated in 24 hours was 100 cc's of bleeding. The most common etiology of the patients enrolled in this study was tuberculosis at 77% of the enrolled patients. And I think that makes it unique, at least compared to the bleeding patients that I see in my emergency department. Most do not have tuberculosis. And so that may be something to be paying attention to. Well, what did they find? Well, the nebulized TXA arm basically did better in all questions. A cessation of bleeding at 30 minutes that was statistically significantly higher than the IV TXA. 72% stopped at 30 minutes versus 50% in the IV TXA. But I do want to highlight that 50% of the IV TXA group was felt to have stopped bleeding at 30 minutes. Now, how many would have stopped with no intervention? I don't have that data, but at least 50% stopped with IV TXA. There was also reduction in hemoptysis volume significantly higher in the nebulized arm compared to the IV TXA arm. No adverse events were identified in either arm, though 55 patients is a small amount, and maybe that's too small a number to be able to identify any adverse events in either arm. So what do I take away from this? Well, I think if we have a patient who is too sick or is otherwise unable to receive nebulized TXA, which is clearly, from the limited evidence we have, showing superiority, I think in those situations when we can't give it, intravenous TXA seems like a viable next best option with limited evidence for any downside. Okay, let's get back to the case.
So TXA one way or another is what I'm hearing.
Yeah.
Any way the TXA goes in will help. I'm going to volume expand, consider my pressors, and try and oxygenate as well as I can. In this case, we were fortunate, and our SATs started to improve. And ultimately, my patient went to IR and then kind of disappeared to an ICU. What's actually happening after that, and what should our patient expect?
So bronchial artery embolization is extremely effective, and in part because of most massive hemoptysis cases originating from the bronchial artery circulation. It's been incredible, the success rates that our interventional radiology colleagues have had in providing immediate control of hemoptysis. In the literature, it's quoted between 70 to roughly 90% of times, which can lead to this immediate sense of relief. You know, we've managed this case. I think we still need to remind ourselves that we need to explore what was the underlying etiology for that hemoptysis event and provide counseling to patients that there still can be recurrence. And there are particular situations where recurrence would be more likely. It would be in those patients with bronchiectasis, those that have an aspergilloma, or essentially a chronic cavitary change where they've now developed a superimposed fungal infection in that cavity. Those are very much prone to rebleeding. And so it may be that bronchial artery embolization brought you immediate or short-term stability, though that patient may still require some discussion with our thoracic surgery colleagues as to whether they would have to undergo a resection, which is less and less pursued because of the success of embolization, but still has a role in clinical care of patients that have an underlying etiology that is prone to recurrence despite other means. To back up a little bit, the bronchial artery circulation accounts for about 90% of massive hemoptysis cases, as opposed to the lower pressure pulmonary artery circulation system. And so it's performed by interventional radiology colleagues. They access the vasculature through the groin. If at all possible, if the patient is stable to undergo this, if they haven't already, they will appreciate if CT angiogram has been performed, just so that they can look if there's any active extravasation that will help guide them to what they suspect is the culprit territory or vessel that accounts for this hemoptysis event. Even if there isn't any active extravasation, they can at least get a sense of if there's any vessel engorgement or tortuosity nearby. Let's say there's an area of consolidation, ground glass opacity in the parenchyma that could help support where the bleeding could be coming from.
If you had the ideal state, Dagny, would you activate the interventional radiology team after you've done bronchoscopy?
Contrary to popular belief, bronchoscopy alone is not typically the kind of final management strategy for patients with massive hemoptysis. It can be a helpful diagnostic tool to at least lateralize, if not more specifically localize where the bleeding is coming from. And apart from situations, let's say, where you have an endobronchial abnormality that can be addressed with some topical approaches or use of thermal therapies, that massive hemoptysis ultimately is predominantly addressed through interventional radiology with embolization.
I was wondering if it would, do you ever communicate where you're seeing the bleeding on bronchoscopy to the IR team, and does that improve their yield of being able to help? Or?
Absolutely. In discussion with some of our interventional radiology colleagues, they note that it's rare for them to, in the moment of embolization, to be able to see active extravasation, and so they very much rely on any available bronchoscopy report, ideally with kind of direct verbal communication about these cases since they're rapidly unfolding. But they're very much in tune with what has been observed in the airway to help guide them, in addition to some of those other clues like the tortuosity or engorgement of vessels.
So a report to IR of there's just a lot of blood and I think it's coming from the lungs is not as helpful.
Correct.
Okay.
Yeah, as specific as we can possibly be. And there are certainly times in the bronchoscopy suite that we generally have a sense of where the bleeding is coming from if it's related, certainly to our biopsies. There are times that those patients then go directly to interventional radiology with a secure airway, meaning that you either have selectively intubated the non-bleeding side, or you've placed a blocker or Fogarty balloon or some sort of mechanical way to keep all of that blood from spilling over to the healthier lung in that moment.
I think we've had a chance to talk a little bit through the EM approach, which we're lacking some of those tools, but it's also a moment where there's a great deal of uncertainty. And so our patient care in this case has ended, but I'd love to hear a little bit more about some of the next frontiers, the stuff that you actually are working with. So I heard you say a blocker and cryo. There's a lot of cool words coming. I just want to better understand what exactly
Absolutely.
we're doing.
Yeah, I think it's very helpful to back up and talk about these different tools to folks that aren't using these on a daily basis or regular basis. We'll start with an endobronchial blocker. There are different brands. I personally have the most familiarity with the ARNT endobronchial blocker that can be essentially loaded over a bronchoscope, whether it's a disposable scope or, let's say, a standard bronchoscope. It has a little bit of a lasso at the end of it that essentially you loop around the distal tip of your scope to help so that when you drive your scope through the airway, this is also going along with it. You insert it with the balloon deflated, can lubricate it just to allow for that passage through, again, that ideally size 8.5 ET tube or greater, and direct it to whatever side or as specific of an area of bleeding that you have. And once you've landed in that portion of the airway, you extend the blocker slightly to get that lasso to come off the distal tip of your scope, and then you, under fiber optic visualization, inflate the balloon just enough to kind of hold a wedged position without overdoing it to the point that you're going to lead to undue ischemic injury to your airway. And that's really just a temporizing measure. Ideally, you wouldn't have an endobronchial blocker in place for more than 24 hours. Occasionally, we end up having to use it for a longer period just because there's ongoing bleeding when we deflate the balloon and check what's going on behind it.
You're already speaking to something I have no experience with. 24 hours is an eternity in my time. I'm trying to get 20 minutes down the line, so we've already won.
You mentioned it's a lasso, so air can travel through the center of this balloon. Is that what that's about, or?
So the lasso is really just there to help with guiding the blocker to whatever area is you've identified the bleeding coming from, and then it glides off of your scope. And so ultimately that lasso is just kind of floating in the airway, shouldn't cause any sort of obstruction, but what in the end causes your obstruction is inflating that balloon. It's just to try to keep the blood distal to that site and prevent it from spilling over to other ipsilateral lobe or certainly to the contralateral lung.
I see. So we're not tamponading the bleeding with the balloon. We're closing off a section of the lung so the bleeding doesn't go into the other areas.
Exactly.
Got it.
What about cryo? And there was cold saline. There's a lot of
there's a lot of different techniques. So a cryo probe is a tool that essentially has a metallic tip. You operate it with the use of a pedal that allows you to freeze that tip. And you can use it for different techniques like tumor debulking. And in the context of this talk on hemoptysis, it's a very effective tool for removing blood clot from the airway. one tricky piece and why it may not be super effective in the emergency department context is it takes time for clot to evolve to the point that it can really adhere or kind of freeze to that tip of this tool. And often the patients in the emergency department, they're obviously very fresh into this course, but more so once these patients land, let's say in an intensive care unit, and we're dealing with all of the sequelae of the bleeding that happened. So any sort of blood that spilled over to the other lung and has now started to congeal and clot. You guide this cryoprobe through your working channel of your bronchoscope, and you extend that metal tip just by 1 or 2 centimeters. You drive it into where your blood clot is. You hold down the pedal, and you visibly watch it freeze to that clot. And then while continuing to hold that pedal down, you pull your scope and, in effect, your cryoprobe out with it. And sometimes it's very satisfying. You get multi-centimeter long clots or even sort of casts of the airway that have been formed.
Interesting.
Other times it can be much more frustrating and you're removing clot in piecemeal fashion.
Yeah.
What's the most outstanding retrieval that you had? Can you walk us through that one?
I think a clot, 5-6 centimeters in length is certainly satisfying and thinking, oh, great, we've extended that much more airway that's open, but you may still have to go deeper down and repeat this technique several times. It's rare to have just a single application of the cryoprobe tool be enough to clear out any clot burden. So they tend to be lengthy cases. Once you get enough of that organized clot out, you likely will reach a point where you can remove your cryoprobe and just use your bronchoscope for its normal suctioning ability. For less mature clot that's kind of still in a more liquid state, and you can suction that out.
I've only seen this technique once, and in retrospect, it was so embarrassing. But I really wanted to learn. One of our intensivists, Dr. Shivo, I was taking another patient up, and I'd forgotten about this other hemoptysis patient, and they were pretty unstable. And so I was a resident at the time, and I said, I'm just going to take this patient upstairs. I'm going to actually physically walk with them because we're very worried. And we called upstairs and said that there was this bleeding. And Dr. Shivo is one of the most incredible educators I've ever met. And I walked in, and I saw him at the head of the bed, and I saw this wild-looking tower. And I was like, I don't know what's going to happen here, but I really want to understand this. So I just walked to the head of the bed and I said, can I stand right here for whatever's about to happen? And I can't imagine now as the attending, if a random person walked up to me with a team that I didn't know and said, I just want to learn this thing that you're doing. Can I stand here? I don't know how I would react, but he reacted as the incredible educator he was. And he said, absolutely, you can stand there, and proceeded to stabilize this critically ill bleeding patient with cryo. And it was the coolest thing. It was exactly what you said. All of a sudden there was this like little cast of the airway came out, and I was very jealous of that skill set, but learned a lot. And so this is a shout out in many ways to our incredible critical care physicians who are great educators and partners of ours.
I know you would do the same.
Yeah.
In fact, I see it all the time. You downplaying what you would do. But
I am much less eloquent than Dante, my colleague in the interventional pulmonary practice. But anytime I'm using the cryoprobe, I can't help but think of the movie Dumb and Dumber. And when Harry licks that
Yes.
hole essentially and gets stuck to it. And that's
Yep.
essentially exactly the mechanism
love
we're
that
using
analogy.
to
That's
adhere to
phenomenal.
the blood clot and pull it out of the airway.
That is so cool. I love it.
I can't pass up the opportunity to remind our listeners that also simultaneously to managing the airway, all the resuscitative advice that Dr. Kreuter gave us in the previous season would be really, really useful. So check out that episode if you haven't. And if you're still unsure about GI bleeding as well, we have a great episode on that in last season. I think we're coming to the end of life-threatening hemoptysis, but I would be remiss without asking, what about ECMO? And then in my mind, I'm thinking, if all else fails, should we just plug up the entire trachea and allow the entire tracheal tree to clot off while the patient is supported on ECMO? Is that really outlandish?
This feels like that meme. It's a bold strategy. It'll be interesting to see how this
Peer
turns
review
out.
if I did this.
All right.
I will say that I've been involved in the care of many ECMO patients really in the context of hemoptysis that more typically has developed as a result of the anticoagulation to support a patient on ECMO and keep the circuitry from clotting. I'm not personally, but it wouldn't be unheard of to at least call the ECMO team and determine a patient's candidacy if the issue number one is hypoxia, recognizing it's being driven by blood or a combination of blood and clot burden throughout the airways. Ideally, then you would allow that clot to mature, go in and retrieve it, and hopefully have a short-lived period on ECMO support so that you don't start running into those mechanical issues related to clotting. Rarely, but I have seen that there's just such extensive bleeding and clot within the airways that the endotracheal tube is simply removed from the ventilator circuit, recognizing that you're fully supporting the patient on ECMO and will have to ultimately go back in through the airways and retrieve all of that extensive clot burden, certainly with the use of a cryoprobe at that point.
So you're saying there is potentially some experience in very extreme cases where you just allow the entire tracheal system to clot off.
There's a chance.
There's a chance.
There's a
Going
chance.
back to Dumb and Dumber.
So there's a chance.
There's a chance.
There's a chance.
In extreme cases, I've seen it really just in a couple of instances, and again, that's such a small sample size, but neither patient had a favorable outcome with sort of such drastic steps.
So we've covered a lot of key topics, which I appreciate. We've gone over a difficult case. We've brought up ECMO because I think everyone should be on ECMO all the time. Shout out to Suraj.
Maybe we try and bring that up every season?
Absolutely.
Or every episode this season?
Yes. When we cover cellulitis, could they get ECMO? 100% they could. But not all bleeding has to be this bad. And sometimes I think that the grayer area, the harder thing is, can this patient go home, and what do I work up when it's not that emergent? So what about a patient who the bleeding is much, much less? A patient comes in and they're in a general care room and a nurse doesn't run and grab you and say, there's blood on the floor, but you see on the chief complaint coughing up blood, and you walk in and you're trying to suddenly start evaluating how much. So walk us through those types of questions and how you approach it as a pulmonologist. How do I start to break through what is concerning and what isn't, and what my next steps are going to be?
I think that's a great question. And thankfully, hemoptysis is something that even in very scant quantity generally raises alarm in the patient population. I think if any of us experienced even a few specks of blood, we would say, my goodness, that's not normal. It would likely lead us to seek medical care, maybe not necessarily emergency department care, but it's rare. Occasionally it happens, but most patients don't ignore hemoptysis. And so they very well could be coming through the emergency department as their initial point of contact. And I think it helps to reflect on what ultimately is going to be the most common cause of hemoptysis, particularly non-massive hemoptysis. And it ends up being, bacterial pneumonia, a viral pneumonia, that are sort of run-of-the-mill issues that are often addressed in the inpatient environment, but may improve just with some antibiotic therapy supportive cares. I think to reflect on when we are evaluating patients in the outpatient setting, which obviously is not in the realm of emergency department scope of practice, but there are certainly patients that come to the outpatient pulmonary clinic for evaluation of hemoptysis that may have been going on for many days, sometimes some weeks if it's a small volume. And often our first steps when we're working these sorts of cases up as an outpatient would be to obtain imaging. There's at least some consideration of bronchoscopy, and often that ends up being performed, especially if it's been lingering for a more prolonged period and there's not a clear explanation. It's not ceased or improved with whatever therapies have been implemented at that point. I think at the very least it would be helpful to obtain chest imaging in the event that can help lateralize a process. Like let's say we at least have a very clear-cut appearance for community-acquired pneumonia. That can prompt antibiotic implementation, and if it's just sort of specks of blood that they are reporting, I think it would be reasonable if it's a reliable patient, particularly a patient that's plugged in with a primary care provider, to send them out on antibiotic cares and certainly counsel them about, if the volume of hemoptysis escalates, kind of regardless of what the rest of their clinical pathway evolves into, then it would make sense to return to the emergency department.
Dr. Anderson covered a lot of ground really quickly there. She's amazing. Let's back up for us who are just beginning and review the differential a little more in depth. When thinking about hemoptysis, especially when there's time, such as in non-life-threatening hemoptysis syndromes, think about traumatic issues, infectious causes, rheumatologic causes, structural issues, vascular issues, and a handful of other miscellaneous causes. Specifically, from a trauma perspective, your patient may have a foreign body, penetrating trauma, a medical stent-related complication, tracheostomy issues, or even a post-procedural complication. These are all fairly relatively common causes of hemoptysis. Dagny highlighted infections as a common cause, of course, pneumonias, but we should also consider tuberculosis, as we saw in the research on nebulized versus intravenous TXA, for example, where 70% of the enrolled patients had tuberculosis as a cause. Less commonly, though, things like anthrax, leptospirosis, Yersinia, and tularemia have also been implicated. You likely know from listening to us for a while now that I struggle with rheumatologic things, and this situation is no different. I need to run forward and think about rheumatologic causes in this situation. Lupus, Chet's disease, antiphospholipid antibody syndrome, and Goodpasture's disease can all present with hemoptysis. From a structural standpoint, cancers and bronchiectasis are two fairly common conditions that I see in my patient population, and you might in yours. Vascular causes like heart failure, pulmonary embolism, telangiectasias, similar to the ones like we spoke with Dr. Olson during the epistaxis episode, and aneurysms or pseudoaneurysms can all cause hemoptysis, and we need to be on the lookout for them. We need to also be thinking about social factors like cocaine and vaping use, as they may play a role in the development of hemoptysis, especially in our younger patients. And of course, amyloidosis is one of those miscellaneous things. It's on so many differentials for etiologies of conditions, whether it be heart or kidney and many other conditions. So having a broad differential can be very helpful. And remember, trauma, infections, rheumatologic, structural, vascular, social, miscellaneous causes. Take a good history and do a good physical exam. Let's get back to Dr. Anderson.
I think when I was in a county ED, we saw a lot of TB as hemoptysis. I would say 2/3 to a half of the patients who had non-life-threatening hemoptysis ended up being diagnosed with TB. Is that your take as well?
In the United States, and certainly in our population here at Mayo Clinic, I would say the top three considerations we would have would be pneumonia, really, of a variety of sorts, bronchiectasis, and primary bronchogenic carcinoma. But certainly that kind of list of your top few items in your differential diagnoses are very much impacted by the population at hand, and worldwide, tuberculosis would be much higher on that list compared to here.
Okay, so we have our differential. We're thinking about infection, we're thinking about cancer, we're thinking about bronchiectasis. Bronchiectasis is one that, to be honest, I don't fully understand what's happening there. Can you explain what that disease is?
I'd be happy to. And so bronchiectasis is a term for describing what should otherwise be a natural tapering of the airway when you go from trachea to your main stem bronchi to your lobar bronchi and kind of more distally, that there should just be this gradual, smooth tapering effect until you get all the way to the distal airways abutting the pleura. Bronchiectasis means that you've lost that gradual tapering, and once you get further into the periphery of the lung, you see a larger caliber airway than what you would expect for how distal out into the airway you are. And certain conditions like cystic fibrosis are a cause of bronchiectasis, but there is an incredibly wide variety of etiologies of bronchiectasis, but ultimately it's a radiographic abnormality that would be commented on by the radiologists.
And how does that lead to bleeding?
It leads to architectural distortion that also makes patients more prone to developing infectious complications. For example, they are more prone to non-tuberculous mycobacterial infections that can present with hemoptysis or present with kind of this smoldering constitutional symptoms or chronic cough.
So that's our differential walking into the room. And you talked about some of the history that we need to get on terms of volume. Any other goals of the history that you might be trying to get?
Absolutely. This is a good time to review the active medication list, get a sense of if there's any anticoagulation or antiplatelet, particularly dual antiplatelet therapy on board, getting updated laboratory evaluation to explore for any evidence of coagulopathy, whether it's related to medication or just an underlying medical condition.
The audio in this segment was a little bit sketchy, so I'm going to summarize some of the other information that we should be gathering on history, or at least thinking about whether they're relevant to your patient. You should be thinking about asking, of course, about how much blood the patient believes they've lost in the last day or 2 days, and is that blood mixed in with mucus, and if so, generally what's the color of that? When did the first episodes occur, and in what context did that occur? Had they ever had hemoptysis before? Are there any other sites of bleeding, whether it's from mucous membranes or in stool? That might be very important. Do they have other associated symptoms like shortness of breath? And are they generally raising a lot of mucus even without blood? Have they had infectious symptoms like fevers, coughs? Maybe have they had rashes or joint symptoms that might point to those rheumatologic causes? Thinking about the malignancy as a potential cause, have they lost weight or had night sweats? That's also relevant for tuberculosis. In women, does the hemoptysis seem to relate to menstruation? Is there any relevance to their cycle or changes in relation to their cycle? Other signs of systemic illness. Of course, from a social history, are they using e-cigarettes, vaping, using cocaine? And then overall general medical knowledge about recent procedures they've undergone, changes to their past medical history, new medications, particularly anticoagulation. Do they have any risk factors for venous thromboembolic disease? Have they traveled anywhere unusual? What is their TB risk factors? Make sure to ask that. And then, are there any unusual chemical exposures? Now that you're caught up, let's get back to the interview.
If you are able to hear that it's inflam, that's a better situation.
That could help point towards whether there could be, let's say, an active bacterial pneumonia. If you have a sense that this is sort of new sputum production for that patient, or if there's any sort of evolving characteristics, like change in color, and you'd also, certainly explore any sort of concurrent constitutional symptoms that could help support that maybe we're just dealing with community-acquired pneumonia that is manifesting with some hemoptysis as well.
So let's transition to physical exam. Obviously, we are looking at vital signs, and we're presuming at this point this patient is pretty stable. Outside of examination of heart and lungs, which I think we would all do, what other key organ systems are you evaluating for hemoptysis?
I would say getting a sense of the overall neurologic status. And what I mean by that is it a patient that has kind of an intact cough reflex, cough mechanism? How strong is their cough? And that's going to be helpful later down the line to, apart from, a very dramatic story like we started out with, helping to decide what sort of patient would warrant intubation. Generally, for those that have an intact cough, as much as possible, just letting them use their cough reflex to protect themselves is very effective. Then they can maintain an upright position and clear their airways independently, rather than jumping to early intubation and then having a patient that's supine, and then you have more risk of blood going to the contralateral lung.
Other things that I tend to look for is also like rashes, bruising, telangiectasias. Are you seeing much of that as being helpful when you're evaluating these non-life-threatening cases of hemoptysis? Or
I would say particularly in the outpatient setting, that very comprehensive sort of review of systems and physical exam exploring, let's say, an underlying connective tissue disorder, vasculitis, would be very wise. I think in the hospital environment, when interventional pulmonary is involved for hemoptysis cases, it usually is in the context of more of the massive hemoptysis situations. Mm-hmm. One other aspect of the physical exam that would be helpful to specifically look for would be any murmurs, any evidence of congestive heart failure manifesting with volume overload. Those are conditions that can lead to hemoptysis and that could inappropriately lead you down a pathway of thinking, do we need to involve pulmonary? Do we need to involve the bronchoscopy suite, when kind of perhaps just initiation of diuretic therapy might be all that's needed to help control that hemoptysis.
How common are you seeing hemoptysis in heart failure patients?
It's not an uncommon scenario, and when we do see it, it's sort of that light pink tinged frothy sputum. It's rare for it to present with kind of active, brisk red bleeding. So it tends to be more subtle, and generally these patients have other overt evidence of volume overload too.
All right. So then let's think about our workup. If we're talking about blood tests, what are you ordering? And are you ordering blood tests on all patients who have non-life-threatening hemoptysis?
I think at the very least I would order a CBC and INR, and then really the rest of the laboratory evaluation would really be guided by what other concurrent symptomatology has been happening.
What about you, Alex? I'm assuming in our case, we don't know if these patients are going to get worse, so we're going to order some more. What are you reaching for?
I would say it's similar.
Okay.
We'll add electrolyte panel, which I'm sure would be pursued anyway, just exploring for the possibility of uremia, making the patient more prone to hemoptysis or other bleeding events.
I love that. Okay. I'm probably paranoid about what you described in that very dramatic case before about how everything looks fine, seems fine, and then turns. So I personally get the CBC and PT, PTT, type and screen, INR, fibrinogen, and then go from there based on other concerns about vasculitis and whatnot. D-dimer is a question that comes up a lot. Dagny, what is your approach to D-dimer in patients with hemoptysis?
So certainly, we haven't touched on this yet, but one of the potential causes of hemoptysis would be a pulmonary embolism that could or could not be complicated by a pulmonary infarct as well. So that would be a helpful parameter to check in the emergency department. And if there wasn't already a compelling sense that a CT scan would be helpful, that might help with that decision tree.
How are you deciding CT versus X-ray? Certainly if you're worried about PE, that pushes you over.
Mm-hmm.
But
yeah, I guess if there's not as much concern for PE and the patient is having non-massive hemoptysis, looks vitally stable and clinically reasonably well appearing, I think it would be okay to start with a chest X-ray. That may help lateralize the site of the bleeding in a small set of patients, roughly 20% of patients. CT scan will certainly capture kind of a much more comprehensive look at the parenchyma and help give a sense of where the bleeding is coming from and what the underlying process is, and will help you lateralize the site of hemoptysis in about 70% of cases.
I'm assuming they're always with contrast, or?
Not always. Often in pulmonary medicine, we can glean a lot of the information we need with non-contrast CT scans. I think what will push you to contrast would be that concern for PE or a massive hemoptysis presentation where you would want angiography as well, just to see if there's any sort of active extravasation or abnormal appearing vessels.
And so what I'm looking for on my CT is atypical vessels, mass, PE, sign of infection or bronchiectasis. Where am I left if the CTA looks pretty clean?
There certainly are cases
That's what we
where
call Dagny.
Yeah.
We'll call either way, actually.
Yeah.
I guess one other thing you can glean from this scan would be if there's any clear evidence that you have sort of clot burden spilling into the contralateral side, that would just be an indicator of higher risk or kind of poorer prognosis situation. But if you have a non-revealing CT scan, then one option, depending on how stable the patient is just to get a sense of, let's say you have enough to kind of warrant antibiotic administration, just get a sense of, will that alone lead to lessening of the volume or frequency of hemoptysis? If it persists and the CT scan really didn't help you in deciding where the bleeding was coming from or what the etiology was, then I think there would be a role for bronchoscopy just to look for any sort of subtle endobronchial abnormalities that didn't raise any concern on the CAT scan.
When we're trying to make a decision of who can go home and who needs to be admitted to the hospital, if a patient has a clean CT, they're not coughing up any blood in the ED, and they were endorsing kind of some blood in their sputum, and the rest of their exam is normal, do all of these patients need to be admitted, or kind of what type of patient can go home with this chief complaint?
So great question, and certainly I think an important and thoughtful question just to help best utilize limited resources. And I think if the patient has ready access to their primary care provider, or let's say they're already plugged into pulmonology for whatever chronic condition they may have, kind of reaching out to that pulmonologist just to have a short-term follow-up appointment set up would be a wise step. But certainly not all of these patients need to be admitted. It's kind of just based on a sense of how reliably that patient would be able to return to emergency care if the situation deteriorated over time.
Locally, we have several patients who have telangiectasia syndromes, and when I've encountered a couple of them for hemoptysis, even if they look well, I've admitted them all. Am I being too cautious with that group?
I don't think so, and thankfully that's such a rare diagnosis that I don't think it would be certainly a common occurrence. I think it would be reasonable to admit patients that have underlying tendencies for bleeding and at least having a period of overnight observation just to get a sense of if that volume of hemoptysis is picking up or not.
I have a few questions that don't fit into some of our other discussion areas.
Mm-hmm.
Do you mind?
Oh, I'd be happy to address this.
Do you see any role for ultrasound with or without contrast for evaluating hemoptysis?
That is a great question. I haven't personally used bedside ultrasound for that indication. And certainly our interventional pulmonary group is very much, we come into the room holding bedside ultrasound for our pleural cases. I presume, if you had one lung full of blood or clot, you'd have loss of lung slide. But I personally have not used that tool to help kind of guide the rest of the management, but certainly would be a reasonable thing since it's already sort of readily accessible in most emergency department settings. And let's say a patient isn't stable enough to go off to CT scan. But I think if you were in the situation where you have one lung full of blood or spilling into both sides, probably you're already down that pathway of intubation, and then you'll get your live fiber optic view as a first step.
Prior to COVID, vaping was gaining a lot of attention for its lung injury. How does that associate or not with hemoptysis?
Vaping can induce hemoptysis. I would think more so, though, of other presentations such as new hypoxic respiratory failure, new infiltrates on CT imaging that are otherwise unexplained. But it's not a common etiology that we ultimately discover as the source of hemoptysis.
Okay. Now, getting to bronchoscopy in the non-life-threatening patient group, when are you considering bronchoscopy, and should we be considering it in the ED?
I think for non-massive hemoptysis, it would be completely acceptable to defer the bronchoscopy in the emergency department, have the patient, if you have enough kind of clinical gestalt to justify admission already, have the primary team monitor the volume, sort of the pace of hemoptysis over the coming day or days. And if there's no improvement, despite, let's say, correcting coagulopathy, holding anticoagulants, antiplatelets, treating for possible pneumonia, after a few days, I think it's very reasonable to have that team request for an inpatient bronchoscopy just to look for any sort of endobronchial abnormalities that, one, need some form of explanation. Is this a new manifestation of a malignancy? And to be able to offer some local therapies if that's encountered. So some local therapies include thermal techniques like APC, which stands for argon plasma coagulation, that effectively coats that area on a superficial level and has a coagulative effect.
The other group that we haven't talked much about are those who have trachs, and then there's blood that came out, especially like from a nursing home, but there's no longer any blood in the suction. What's your approach to that? And I always worry about the tracheonominate fistulas. And
Perfect. It's a fantastic question. Certainly I would want to know how recently was this tracheostomy placed, because that window when you would wonder about a life-threatening complication like a tracheonominate fistula typically would take a couple of weeks or beyond to manifest itself. It's not something we would generally think of as, let's say somebody had a tracheostomy placed yesterday, they're in the ICU, they're bleeding. Often that's kind of venous vessels that are oozing, and are a nuisance to keep up with and keep that site dressed and clean. But it's not the type of timeline that you would anticipate a fistula would have formed within. So getting a sense of how long ago the tracheostomy was placed, what size trach it is. It's rare that you're going to have the equivalent of an 8.5 or greater tube. So depending on kind of the overall clinical picture, you may have to intubate from above just to be able to pass the types of tools that you would need, for example, for that first case that we were talking about.
Dagny, you've been amazing. Thank you for covering such a colorful topic with us. Are there things that we didn't ask, but you think our listenership of emergency medicine physicians, PAs, NPs across the globe would want to know?
One thing that we haven't talked too much about is bronchoscopy-related complications. So, for example, from a counseling side, when we finish a bronchoscopy procedure and we chat with the patient and the accompanying family member in the PACU, we give some guidance about what they should be watching out for. So certainly sort of blood-streaked sputum or small specks of blood would be very much expected within a day or two after any procedure that involved biopsies, whether parenchymal biopsies or less commonly an issue, but can still occur with lymph node-related sampling within the chest. But we give that guidance that if you have a more significant amount, and that can be arbitrary depending on who's doing the counseling, like let's say a tablespoon's worth of blood, which again is so hard to quantify, that they should seek emergency care. And so we are giving some guidance from our side about when to seek ED care. And so I guess one other thing to be running through your minds would be, has this patient had a recent procedure that very much would have been a setup to have a bleeding-related complication? And thankfully, then the kind of the localization is much easier because we would know, what down to the segmental level, where were we taking our biopsies from? And typically with bronchoscopy-related bleeding complications, those tend to happen right away before we conclude our case. They lead to perhaps extension of the case to get that under control before you would remove your bronchoscope, but it can have a delayed presentation. And so certainly looping back in with the team that performed the procedure, and then they're kind of looking quickly through the operative report, okay, they were doing right lower lobe biopsies, get them on the right side down there. You don't even have to wait for your imaging. You already have almost 100% confirmation of which side it was coming from. And the types of populations where we're performing transbronchial lung biopsies are those, let's say they've had lung transplantation, which our personal practice here is such that that volume of patients has really skyrocketed within the last year. It's just a very exciting, also very complex patient population to care for, but they routinely get surveillance transbronchial lung biopsies to assess for any rejection. And we sample only from one lung. We often sample from, let's say, right upper lobe and right lower lobe, just to know if there's any hint that rejection is occurring, because that'll guide their immunosuppressive regimen. We would almost never, or very strong, I would say it would be extremely rare to have transbronchial lung biopsies performed bilaterally, just because of both the pneumothorax and bleeding risks, and then having no ability to really stabilize a patient with simple techniques like positioning.
That's incredibly helpful. I didn't know about the complication or the complications to look for after bronchoscopy.
I think I would have just called, but now at least I have some better understanding of what's. That's fantastic. If their bleeding seems to have resolved and it was seemingly minor, but they had a bronch earlier in the day, can they still go home?
I think if during a period of observation in the emergency department there haven't been any ongoing events, I think after a quick phone call with the proceduralist, or at least the procedural team, that would be a reasonable approach, because old blood can, be located rather distally, and this is the patient just using their intact cough mechanism to clear their airways. And so it could just be the blood that wasn't able to get suctioned out.
Well, Dagny, thank you so much for covering all this with us. We really appreciate your time and your expertise, and I know our listeners will as well.
This has been amazing. Thank you for working through a challenging case with us, and we learned a lot.
Thanks very much. It's been a pleasure.
The take home is, don't be Alex's patient. You'll have hemoptysis and it'll go badly, but he'll save you because he's amazing.
the Always On EM podcast, hosted by Alex Finch and Venk Bellamkonda.